This week on the BackTable Podcast,
the best thing as oncologists that we can do is make sure we're asking patients what their major concerns are. We go in with a laundry list of things that we want to know because we want to know if their cancer is back, right? So we have a checklist. And I think sometimes we get so caught up in that checklist that we don't really stop. We'll say, do you have any questions at the end of the visit? But I don't think that necessarily opens the door wide enough for some patients to really bring in anything that's on their mind. And so I think we really, really need to make sure if there are any other concerns you have today, or anything we didn't talk about that you would like to talk about, just getting to the heart of what's important to patients. So everyone's asking about hot flashes. Everyone's, asking if they're taking their medication, fatigue. But I do think there are some providers that spend more time on that than others. And I hate to leave it up to the patient to be able to get all that information.
All right, welcome to the BackTable Podcast. I'm really excited to get into this episode and talk about survivorship in breast cancer today with Lindsay Peterson. Before we get into it, I just wanted to do a quick plug for the BackTable app. If you haven't checked out the app yet, it's a really cool resource and there's lots of different functionalities to it. I think both Lindsay and myself have created podcast playlists on the app. So feel free to check those out. Those are available to the community to view. So just wanted to quickly plug the app before we get started today. But super excited to delve into this really important topic of survivorship today with you, Lindsay. Can you tell me a little bit about yourself and your role in survivorship and how you got interested in this topic?
Yeah, of course. So super excited to be here. Glad we're doing this topic. Very important, as you mentioned, for all of our patients. So I'm an associate professor of medicine at WashU in St. Louis, and I'm the director of survivorship for Siteman Cancer Center. And I really got into survivorship, I think, at an early stage. There was a strong interest in lifestyle medicine, right? And the importance of diet and exercise. And that really ties into, I think, finding other ways to help people get through their cancer journey, minimizing side effects, making the most of what we can. We have all the treatments, we know what we can do from a long-term standpoint with medications, but it causes a lot of problems for our patients. And so finding alternative ways, non-pharmaceutical ways to help our patients get through those treatments and live a long, good life was something that was very interesting to me.
That's great. Yeah, I share that interest. I serve as our medical director of supportive care services, survivorship being one of those. And I think at Tennessee Oncology, where I work, we have a really strong survivorship program. And I think it has really helped my patients deal with the long-term, especially breast cancer patients, right? Those patients are really engaged in their care and they have to be on their therapies even for curable cancer for 5, maybe even up to 10 years. And so helping to make those therapies more tolerable has been a passion of mine as well. So I'm excited to get into talking about this with you today.
Awesome. Yeah, it's important to the patient, so it should be important to us, right?
Absolutely. When you see a patient for their first survivorship visit, let's say a patient had surgery, finished all their chemotherapy if they needed any of that, and maybe are transitioning to endocrine therapy or whatever long-term therapy they're going to be on, what are the top things on your mind when you're seeing the patients? And what are the top things on the patient's minds?
Yeah. So, we've recently sort of adjusted our model a little bit. So that longer term survivorship that you're referring to, I think is a pretty common model, one that a lot of people have where we sort of transition patients after their acute or active therapy to longer term surveillance. We've also started a new acute survivorship clinic where we see patients right at the beginning of their diagnosis. And so those discussions are very different, as you can imagine. Their needs are very different. So for those patients who are done with their active therapy and they're coming in, really what I want to get across to them is that if they're open with us about their symptoms, their side effects, what they need, then we can help them. But our concerns really are their concerns at that point. And so we want to make sure that we're addressing those things that are important to them. And really that first visit is the same thing. What are their concerns? But it's focused really on social concerns, emotional, financial. How can we help them with all of these things that aren't necessarily a core component of their primary oncology visits? And I think at both of those visits, we're really stressing the lifestyle. We're stressing how, from a nutrition standpoint, a physical activity standpoint, these things can help them feel feel better and in some cases even improve their outcomes.
I totally agree. And I like that model of having a separate survivorship visit sort of at the beginning of somebody's acute care, because I think that provides that extra level of support. We're even doing a pilot program for patients with metastatic breast cancer who are stable on therapy for a while, because we know patients, especially with endocrine or with hormone-positive metastatic breast cancer, can be stable for many years on endocrine and CDK4/6 inhibitors. So we're piloting involving survivorship plans in that space as well.
That's awesome. Yeah, that's a huge need too, right? I mean, these patients, they live a long time and they're on treatments just like our adjuvant patients for a long time. So I think that's really great. I think that's a population that doesn't always have access to these services and they can absolutely benefit from them.
I'm curious how your survivorship program is set up. Like, how does the clinic work day to day? How are you identifying patients appropriate for survivorship and getting them in? And who's seeing these patients?
Yeah. So the acute survivorship clinic, those patients are being identified both through their own medical provider who's seeing them, perhaps starting them on chemotherapy and referring those patients. Although our clinic manager does do a decent job of looking for, are there patients we're missing? Maybe the provider forgot to bring it up or, for whatever reason, maybe they didn't get referred at the beginning. And so we are trying to find those patients to offer the services to them. Those patients are seen by an advanced practitioner. And in our longer-term surveillance clinics, that's the same thing. So we have APPs that run those clinics. But what we try to do is we try to make sure that when a physician works with an APP, we know that patients during active treatment are going to see that APP intermittently. And so we try to make sure that it's that APP that's seeing those patients in the longer-term survivorship clinic. So we have that continuity. We have that trust. I think that makes a big difference. And that's, again, a different model from the acute survivorship clinic. But most of those acute survivorship visits are a one-time visit or perhaps a two-time visit to just really focus on, here's the information we want you to have to help you get through this. And then we have a lot of patients who come back. Perhaps they've gone through chemotherapy, they're about to start endocrine therapy. As you know, that's a whole new set of things that they deal with. And so we do sometimes see those patients twice, but all these clinics for the most part are run by APPs. We're obviously very involved in getting these clinics running and throughout time, making sure it's keeping up with what the patient needs are. Getting more and more services available and integrated into those clinics is also really helpful.
That's awesome. Yeah, we work with a company called Oncology Care who helps to manage some of our or most of our survivorship needs. I think actually all for solid tumor. They're fantastic. It's mainly APPs that are seeing our patients as well, supervised by MDs, primarily via telehealth, which I think has expanded access to patients because we have clinics all across rural Tennessee. And so it can be hard for patients to come in for in-person visits, like if somebody's only based in Nashville, for example. So I think that's really expanded access to patients, as long as patients are capable and have the technology to be able to use telehealth appointments. And sort of the cadence of visits depends on the patient's needs and what they're currently experiencing at that time of treatment.
Absolutely. I think, since COVID, we've done more and more telehealth and we've found sort of the sweet spots for where to use that. And I think this is a great, space to do that, especially like you said, from an access standpoint. I think, when patients have been followed by our oncologists for, a couple years, 2, 3, 4 years, we basically say when a patient has gotten to the 2-year mark, it's up to the oncologist to determine if that's the right time to refer patients to survivorship. Sure. If you have a patient with a lot of lymph nodes or, a lot of symptoms, you may want to hold on to them for a couple of more years. So there's no, definitive time at which we send patients, but we do like to keep them with their primary oncologist for 2 years before switching, which that's a different model at different places. There are some patients who get referred right after their active treatment. And I think there's pros and cons to both approaches. I think as long as they're getting what they need and what works for your center, with your providers is both of those, I think, are, very appropriate models.
We have sort of a concurrent model, too, where, especially for the patients on endocrine therapy, they'll see me every 3-6 months, once a year, depending on what their needs are. But they're also at the same time seeing the Recovery Care team via telehealth, which I think is so fantastic because in a 15-minute oncology visit, there's only so much that I can address. And we'll get into all the specific needs that breast cancer patients have from a survivorship perspective. But I find it very helpful as an oncologist because these survivorship visits are an hour. And so they have a lot more time to delve into, hey, I'm having all these joint pains. What are some non-pharmacologic things I can do to help with joint pains or, any of the other things that come with being a breast cancer survivor? So I found it particularly helpful for the breast cancer population.
Yeah, that's amazing. It's such a great idea to have both options, right, for patients going through. And especially because, like you said, the survivorship aspect is telehealth. It's not an extra visit for the patient, right? We're not making them come in a separate time. So, I think the more access they have to providers to help them through this process, the better.
That's great. How does primary care fit into this model? I think a lot of times, but like in the absence of these survivorship models, I feel like the primary care physician would take over a lot of this survivorship care. So I'm curious how you think about primary care in this model.
That's funny. I just got an email today from a primary care physician who I think is looking to get the primary care more involved in our survivorship model. I will say, I love the idea of having primary care embedded in oncology, and there are institutions that do this. Essentially, they're internists, family medicine docs, primary care providers who are embedded in the oncology division. They're available to be the primary care doctor for our patients from day one. And then they're also kind of like the idea of the APP, right, from the beginning. Then when they are transitioned long-term to the primary care, they're part of the team. It's someone who knows, and you've got that comfort level, that frequency of communication between the primary care and the oncologist, because I do think the right model is oncologist for a set period of time, survivorship clinic for a set period of time, and then back to primary care at some point. And a lot of primary care doctors, understandably, aren't comfortable managing these patients, whether that's from a survivorship issue, or other standpoints. And so I think that having them a part of the team from the beginning is a huge value. Now, getting that done can be difficult if it's not already the way that the institution does it. I think that communication is so important between the primary care doctors and the oncologist, and ideally getting them involved early and really just bringing them in as part of the team. And then everyone can decide when the right time is for that patient to be able to follow up with their primary care doctor. Because, I find a lot of patients, I'm sure some of yours are the same way, where they get a little PTSD coming back to our clinic.
Yes.
They don't want to sit in the same waiting room with patients going through what they went through 5 years ago. And so if they can get this care at, a place that doesn't bring back all of those memories, that for a lot of patients is really important to them.
Yeah, absolutely. I have a patient that tells me he gets nauseous every time he comes into the waiting room because of the nausea that he had with chemotherapy. So.
Yeah, it's real. It's important. And I think, whether it's a primary care visit or whether there's a separate space for survivorship, I love when there can be an entirely separate space for these patients, a different floor, a different building, same concept, right? And they may even see the same providers, but just giving them, a little bit of a break from constantly going back to potentially what they went through in the beginning.
Absolutely. Well, let's get into some of the issues that specifically affect breast cancer survivors, starting with recurrence anxiety. I was in clinic today and saw a patient who was over 5 years out from diagnosis and was still asking for PET scans, was still very concerned about recurrence. She had a high oncotype, but she had done all the things. Chemotherapy, endocrine therapy, and now is just on surveillance. How do you handle that? And how do you counsel patients on balancing recurrence monitoring with quality of life and scan anxiety and all of the issues that come with doing scans?
Yeah, it can be hard, right? I think the first thing to do is always validate fears of recurrence are real. I don't think there's anyone, including ourselves, who wouldn't have some degree of those, fears of recurrence. So I think the first thing I try to do is understand how much this is impacting them day to day. I think there's sort of a sweet spot to where those fears should lie, not so far in the front of our brain that, we stub our toe and think there's cancer there, but not so far back that we ignore hip pain for not 6-9 months. And so I think finding out how much it's impacting them is helpful in determining how to talk to them about it. So validate, number one. Number two, in terms of the scans, I think that's a conversation we all have on a regular basis. And some patients, I think, are more understanding of, the rationale behind it. So I do try to explain the rationale. I try to explain, as of yet, we don't know that picking up a recurrence when it's asymptomatic on a scan is going to, improve their survival, as opposed to that recurrence, showing itself with some symptom later on. So I give them that message. I also explain all the downsides to scans. So, of course, there's the financial toxicity, but there's also the fact that we cause 5,000 to 10,000 cancers a year from radiation from all of these scans. And so for the vast majority of patients who are never going to recur, we're putting them at risk with absolutely no benefit. And even for those who will recur, we don't know that there's a benefit to picking it up early. So I think it's a conversation of understanding where they're coming from, helping put it in context in terms of their own recurrence risk, and explaining some of the downsides to scanning. And it's a conversation with some people I have almost every visit. It's a hard thing, right? But it's also part of the do no harm, right? There's things that we do too much, and scanning can absolutely be one of them. And then, of course, I tell them that, there's good studies showing that CBT, cognitive behavioral therapy, can help with those fears of recurrence. And I tell people, if you're seeing a therapist, whether they're talking about it or not, they're probably doing some form of CBT. And so offering them a referral to the psychology service who's used to dealing with patients with cancer who have all of these fears is helpful. And a lot of patients are not always open to it in the beginning, but I find if you really talk to patients about, what we might be able to help with, that a lot of those patients are open to speaking with the psychology service or their own counselor or therapist. I think that can be super beneficial too.
I totally agree. We actually have behavioral health embedded as a part of our survivorship program, separate from our psychosocial oncology services. The survivorship team does COCM behavioral health, which I think has been really beneficial for patients specifically around this anxiety of recurrence topic. And I think behavioral health is so important for cancer survivors. It's a trauma, right, to go through this. And so that it's very understandable to have a mental health component of this. And I think addressing that is just as important as the physical components as well.
Yeah. And I think one of the things too is with anything, the earlier you bring it in, the very beginning of the diagnosis, acknowledging you're going to at some point have these fears of recurrence, right? But there are things we can do about it. So normalizing it for them, I think just them knowing that this is normal, I think take some of the weight of it off of them, knowing that I'm not the only person feeling this way. And I love the idea of having psychology services embedded in any of the clinics. I would say the number one referral we make from our acute survivorship clinic is to our psychology service for individual counseling. And if I mention that in my, new patient visit, the uptake rate for that is probably 5-10%. But in the survivorship clinic, where you mentioned we have an hour to sit there and talk to them about, the potential utility of this, I would say, 2/3 of a patients who it comes up, accept the referral. And so just having the time to stress the importance of these things and talk with patients about where they really are, ultimately, I think serves them because they get more referrals, they buy in more to the services that are available to them.
Right. Totally. 100% agree. Well, let's switch gears a little bit and talk about endocrine therapy, the most common thing that I prescribe to breast cancer patients. But I would say, at least in my practice, a lot of my patients struggle with endocrine therapy toxicities. Is that your experience as well? And what side effects are you most commonly seeing?
Absolutely. Yeah. I think what's so hard for patients is they do their chemo, they do their radiation, they do their surgery, they think they're done with the hard part. And then it re-enters their mind what we said that first visit was, and then there'll be a pill for 5 to 10 years. So many side effects. That said, I always do counsel my patients. There are patients who have no side effects at all. right? So I want them to understand that is possible. I find there's fewer side effects across the board with tamoxifen than with the aromatase inhibitors. Maybe about 40 to 50% of my patients really tolerate the tamoxifen perfectly fine with no issues. And I think with the aromatase inhibitors, that's probably closer to 20% of the patients who really have no side effects, just anecdotally. But I think, obviously hot flashes, vaginal dryness, libido issues, weight gain issues, fatigue, and then, the big one with the aromatase inhibitors is obviously the joint pain.
Yes. That is the number one reason why I find patients want to discontinue therapy is the arthralgia. How do you handle that? Let's tackle these sort of one by one. How do you handle the arthralgias? I find a lot of patients, can't take NSAIDs for whatever reason. Are there any non-pharmacologic things that you recommend for patients with arthralgias? And then do you find that the arthralgias get better with time? That's one thing I've anecdotally heard as well.
Yeah. I definitely counsel them on the options, non-pharmaceutical options. So obviously, we've got the high quality studies with exercise and with acupuncture showing the benefit in terms of reducing the arthralgia symptoms. And really the reduction in benefits is pretty similar to what we see with pharmacologic interventions. So I always counsel them on activity. And for patients who aren't very active, I don't frame it as exercise. The studies, they put patients in the gym, 3 days of cardio, 2 days of strength, but I frame it as just be as active as you can. Do as much as you can throughout the day. And the more you do, the less you're going to notice these symptoms. And that is something patients absolutely come back and report. I started playing this, I started playing pickleball, or I started biking, or I started doing whatever, and absolutely their symptoms get better. Acupuncture is a little tougher because it's usually not covered by insurance, so that's usually out of pocket, right? So, and then some patients are more, open to those types of alternative treatments than others, but I do think that's another good option for patients. There's some data about vitamin D, getting that at the appropriate level, so I do typically check a vitamin D level if a patient's reporting these symptoms. But in terms of, if it's really bad, what do we do? Most patients, I'll switch their AI before I put them on, something like duloxetine, just because it's another pill. And most patients don't want another pill to manage the side effects from their pill. So I usually will switch, and I find, 40 to 50% of the time, the arthralgias are better. The question is, are they trading it for a different side effect? So that they go from no hot flashes and joint pain to no joint pain, but hot flashes. But even in that case, I always tell patients it's either going to be better, worse, or the same. And depending on which one it is, we still have options, right? We have a third one we can try. Ultimately, for the lower risk patients, we also have tamoxifen we could move to if needed. But I do give that option to everyone. And I have some patients who say, let me try exercising more and see how that goes. Or I don't want to switch because I have no other side effects. I'd like to try the duloxetine. So I really leave it up to the patient. But there are several different options. And I do think that they get better over time. And whether that's just the fact that they're getting better or that patients learn to manage them better, I'm not sure. But it is something that I do tell patients. Like, it's not necessarily going to continue at this level of severity, throughout your whole 5 to 10 years.
Yeah, completely agree. That's sort of my experience as well. When you're switching somebody, let's say from letrozole or anastrozole, what's your go-to pick for what you'll switch them to?
Yeah. I mean, I find people tend to either start with an anastrozole or letrozole, right? You kind of have two different camps, and obviously they're equally effective, and so there's not a lot that goes behind that. I know some people like to switch from, non-steroidal to steroidal, but I usually switch from anastrozole to letrozole or vice versa because it tends to be cheaper for a lot of patients. The exemestine's more expensive, and so that's usually what I do. I know a lot of people will switch to exemestane if that's the case. I will tend to do like a mini washout period, mainly just because I want to make sure we're not attributing it to this and it's really something else. It's unlikely, but I've had patients diagnosed with, other inflammatory related arthritis conditions when we thought it was from this medication. So I do usually say, stop 2 to 4 weeks. Let's see if your symptoms get better. They don't need to resolve, but if they're clearly better, then we're comfortable saying this is what it's from, and let's try one of the other ones.
Yeah, totally.
Yeah.
Well, number 2 complaint that I get is the hot flashes for sure. And those can be tricky to manage as well. I would say in my practice, I'm usually starting with something like venlafaxine if they have hot flashes. And then if no response to that, thinking about other potential pharmacologic options. I'm curious as to how you approach that.
Yeah, I think it's evolved a little bit with the newer, hot flash treatments that we have, but that's absolutely how I would approach it. I generally would say, we have three major drugs we can use. We can use, the antidepressants, we can use the oxybutynin, or we can use the gabapentin. So my first step is usually, do you have any mood or anxiety issues? Do you have an overactive bladder? Or do you have neuropathy? Or do you have trouble sleeping? Right. And if that's the case, then, some gabapentin at night. The oxybutynin, I think, works pretty well for people, but the dry mouth can be limiting. I think the SSRIs work maybe not fantastically. I think they improve them, right, a little bit, but they still tend to be bothersome. So, now that we've got things like the Veoza and the Linket, I mean, those things tend to, in some patients, completely get rid of their hot flashes. They're amazing.
But I find that I have trouble getting insurance coverage, and they're so expensive.
They are expensive. Mm-hmm.
So that's why I tend to start with venlafaxine, just so that I can say that if it doesn't work well, then they failed one, and then usually insurance will cover Veoza from there.
Absolutely. So many of our patients are already on an SSRI. Sometimes I'll just say, well, they're on it and it's not working. I would say until these came out, Effexor was by far my go-to, unless I had a different reason to give them the gabapentin or the oxybutynin.
Mm-hmm. Mm-hmm.
I've done some appeals and been able to get it approved. I absolutely have had patients where their insurance company requires that we try something else first and they fail them. But, patients go from 20 hot flashes a day, some to literally none. Whereas I feel with all the other treatments we've had, we're just reducing the number. We're really not eliminating them. So I think this has been a really huge, step forward for patients in terms of hot flash management.
I totally agree. I've seen radical improvement on Veoza, and it's pretty amazing for patients who previously were suffering, through all of this. How do you talk about sexual side effects in clinic? Things like vaginal dryness, decreased libido. I feel like this is an under-addressed topic, a topic that patients are hesitant to bring up on their own. It really does require in some cases, providers bringing it up.
Absolutely. Yeah. I think one of the things I've seen with our acute survivorship clinic is that is an excellent place to bring up the fact that they might experience sexual side effects. I'm shocked at how many, I guess I'm not shocked, but so many have them to begin with, right? They have baseline issues. And then I can tell them, well, they may or may not get worse, but if they do, then they know to expect it. I always tell them, to bring it up with their primary oncologist. But I've had patients who walk into the survivorship clinic, zero distress, nothing checked off on the distress screening. And then I ask about sexual side effects, and we spend the next 50 minutes talking about those. And so you really do have to inquire. And I think the more comfortable you are talking about it, the more comfortable the patient is talking about it. Mm-hmm. And so I'll get very specific with them. Do you have problems with, is it your libido or is it just vaginal dryness? And if it's vaginal dryness, do you have insertional pain or do you have pain regardless? And because we have things to treat all of those, right? I mean, I tell patients, we have topical lidocaine for insertional pain. We've obviously got the, different moisturizers, and for certain patients, even the vaginal suppositories, hormonal and non-hormonal. Now we have procedures, right? Laser therapy and radiofrequency ablation procedures. And then we've got medicines for libido too. And so I really try to let patients know that it is not even possible, but likely, I would say, that they're going to have some sexual side effect, and that we're here to talk with them about all of it. If it's, something we need to refer to, a gynecologist who specializes in sexual health, then I'll absolutely do that. But so much of this management, I think we can do in the office.
Yeah, I totally agree. And on the vaginal estrogen piece, I feel like historically that was controversial, but now there's fairly good data to suggest that is completely fine to use in patients even with hormone-positive breast cancer.
Absolutely.
And that can be really life-changing for patients with the vaginal dryness, especially my older women who are already experiencing that with menopause, and then this endocrine therapy just makes it all so much worse. And I had one patient who was told by her gynecologist that she couldn't use the vaginal estrogen. And I was like, no, we can do it. It's okay.
Yes. Yeah. I don't think that message has gotten across to everyone. And I think there are some people that aren't oncologists, right, that don't feel comfortable, giving the patient that go ahead. But yeah, I mean, of course, with tamoxifen, Any tiny amount of systemic absorption from a vaginal estrogen product is nothing on top of for the premenopausal women, the estrogen that's already floating around, right?
Yeah.
And then in the postmenopausal woman, we're blocking the receptor anyways. I think where the hesitation has been with the aromatase inhibitors, where they're, meant to work in a low estrogen environment. But the meta-analyses that we have, the data that we have, there was one study, I think, that, showed maybe increased risk, but the bulk of the data shows that there's no increased risk. And so I still tend to do the stepwise approach, and save the vaginal hormones for later lines, but I do not have a problem doing that in a patient, who's failed our non-hormonal options. I think, it's very common, and I think that patients should feel good being on it. Doctors should feel good prescribing it, and we sometimes do have to correct information they've gotten from other places.
Absolutely. All right, well, let's switch gears again and talk about bone health. Another common problem, especially for patients on aromatase inhibitors, which can decrease bone density over time in a population that's already at risk for osteoporosis. So how do you counsel patients from a survivorship standpoint on bone health and what to expect over time?
Yeah, I think we're doing more and more bisphosphonates up front in patients. Obviously, we've got the data in terms of reducing the risk of bone density decline and fracture when they're on AIs. But the fact that we can reduce the risk of bone recurrence in these patients, I always tell them that, right? I got 2 reasons to give it to you. So we went from only using it, I went from really only using it in patients with, baseline osteopenia or osteoporosis to now, if you've got normal bone density, well, 1, you might decline over time anyways, right? And so hopefully we can keep you normal. And 2, now if you're at moderate or high risk, we can also look at this as a breast cancer treatment, essentially. So I think a lot of the patients are on the bisphosphonates in my practice, and I think in many, even before they transfer, to survivorship. I do have patients decline. Combination of the side effects, the concerns, the osteonecrosis of the jaw, despite how rare it is, really scares people. And so I do have patients that decline, and then I monitor their bone density, and I might start them later. But I do counsel if I'm starting them later, I don't know if we're getting any benefit in terms of that bone recurrence, but we should still hopefully, starve off some of that, bone density decline that we might see, especially when they're on it for 10 years, right?
Right. Yes. Extended endocrine therapy, they are certainly at risk for bone density decline. Absolutely. Yes. I have a lot of patients on bisphosphonates as well. And especially in that setting when it's every 6 months or once a year, it's a very easy intervention to get in clinic.
Yeah, it's not very burdensome, right? We always try to match it up with their appointments. And if, their Zometa's due in May, but they're not coming in till June, I'll just push it till June, for the most part. And again, make it easy for them. That's what we're really trying to do is improve outcomes without, adding any additional burden.
Absolutely. Absolutely. I'm curious because in the community, when I started practicing out in, a rural community, dental care is not all that prevalent. And so I'm curious, how at your institution or how you think about, is it really all that necessary to do a dental evaluation before bisphosphonates? And when would you hold, other than for renal function issues, is there a reason that you would hold off on giving a bisphosphonate?
Yeah, it is interesting how hard dental care can be to find. I have patients who just can't afford it. If they don't have dental insurance, they just can't afford it. They can't find a free clinic, or reduced cost clinic is still too expensive. So I've been really impressed by that over the years, that it's not as easy as we would think for a lot of our patients. So yeah, I think I will say institutionally, we generally speaking have gotten dental clearance for patients. However, in talking with our bone health specialists, I think we're doing that more than we need to. If I have a patient who tells me they go to the dentist every 6 months, who doesn't have any impending tooth extractions, whose mouth looks good on exam, I don't always send those patients for dental clearance. If I have a patient who I can tell has poor dentition, hasn't been to the dentist in years, tells me they have a history of extractions or implants, those are the patients that I want to get dental clearance for. So I think we probably get it in too many patients. I understand that desire. We all want someone to check a box saying it's okay, right?
Totally.
Yeah.
I always feel better, but
right, exactly. But are we really doing the patient a service? And I think sometimes it's not so necessary. I think we do have to ask the questions, right? I have found patients who I'll say, any recent dental work, and they'll say no, and then they'll go to the infusion suite to get their Zometa, and of course they're asked the same questions, and then they say, oh, wait, you know what? I forgot I did have something, a month ago. And so we do have to ask. And so that's to your second question, when do I hold? I don't know that we have a good number on how far out we want these patients to be from like an extraction or, some jaw manipulation procedure. I typically go with 3 months.
That's my practice as well. Yeah.
So if they've got something coming up, I'll wait, and I'll say, well, wait at least 3 months. And if they obviously have healing issues, waiting even longer. But, we don't see it a lot when we use it every 6 months. We see it more in the metastatic disease when we give it monthly is where we get more of that osteonecrosis. So I think I've had one, at most 2 patients in almost 15 years have ONJ from Q6 month zoledronic acid. So I do try to reassure patients, but it is real and it can happen.
Yeah, for sure. Well, great. And then speaking of bone health, calcium and vitamin D supplementation, I think we touched on this a little bit, but how much are you counseling your patients to take? That's a frequent question. I'm like, sometimes patients are like, well, I'm on this multivitamin. Is that okay? What's your practice on that?
Yeah. So I usually tell them to, if they're able and willing, track what they eat for a week or so, with MyFitnessPal or Lose It or one of these apps, see how much they're getting through their diet. Because, obviously getting any minerals and nutrients through your diet is better than a supplement. The fact of the matter is most people are not getting the recommended 1,200 milligrams of calcium and 800 units of vitamin D. And so some patients just prefer to supplement it all. I will say, in some patients who do that, we then find they have elevated calcium when they come to see us, and we have to back off to once a day. So in motivated patients, I'll have them figure it out. And if they get 600 to 800 in their diet, then I just tell them to take a 600 milligram tablet once a day, as opposed to someone who gets very little dairy and probably needs to do that twice a day. And then their vitamin D, I think for a normal vitamin D, 800 to 1,000. But, so many patients are low. And, I think we still don't know what that optimal vitamin D level is from a breast cancer health standpoint. I think we have some clues there, and then again, from an arthralgist standpoint. And so I think the vitamin D varies quite a bit. I find some patients need 2,000 a day. Some patients need a high dose for 12 weeks. And then some patients, get a good amount from their diet and, take 1,000 and they are perfectly fine on their levels.
Well, great. I think this has been an awesome discussion around all the different issues that surround survivorship in breast cancer and all the potential side effects that patients can experience on these therapies and even not on endocrine therapy. I'm curious, as we sort of wrap up the conversation, what's one thing that you wish oncologists would do differently? And what's one thing that patients wish we talked about more or did differently?
Yeah. I think the best thing that, as oncologists that we can do is make sure we're asking patients what their major concerns are. We go in with a laundry list of things that we want to know because we want to know if their cancer is back, right? So we have a checklist. And I think sometimes we get so caught up in that checklist that we don't really stop. We'll say, do you have any questions at the end of the visit? But I don't think that necessarily opens the door wide enough for some patients to really bring in anything that's on their mind. And so I think we really, really need to make sure if there are any other concerns you have today, or anything we didn't talk about that you would like to talk about, just getting to the heart of what's important to patients. And again, that's where survivorship, like what you guys are doing, where you've got the model where you're doing both so that the oncologist can have their 15-minute, making sure the cancer's not back, but then they have 30 minutes or 60 minutes at a different visit to go in depth about other things. And I think sexual health is probably the one that patients wish we, talked about more.
Totally.
And I think that can vary so much by provider, right? So everyone's asking about hot flashes. Everyone's, asking if they're taking their medication, fatigue. But I do think there are some providers that spend more time on that than others. And I hate to leave it up to the patient to be able to get all that information.
Yeah, I totally agree. I think survivorship models are so important and increasingly so. And you can tell, I'm also interested in things like value-based care. And a lot of the value-based care models are now requiring that practices build in survivorship programs because we know that they improve outcomes for patients and we know that patients are getting these issues addressed. And so I just all around think that survivorship programs are important to build in, especially for breast cancer, which people are, and especially when people are living longer and longer with breast
Right.
cancer and surviving cancer. So hopefully want to help them thrive,
Exactly.
Yeah. Well, anything else that you want to pass on to our audience about survivorship care before we wrap up this podcast?
Well, I think, kind of as you mentioned that we're now getting to that phase where everyone should be including survivorship. I wish we'd been including it from the beginning. I wish that we could sort of stop thinking about it as this separate entity and just thinking about it as part of routine care. It shouldn't be like, how do we figure out a survivorship clinic and can we figure that out? It should just be, well, we have to, because that's part of taking care of the patient. And so I think it's getting a lot more press, one, because there's more survivors, as you mentioned, right? People are living longer. And also now we're getting studies that show different survivorship, models, different care delivery systems within survivorship can not only improve symptoms and quality of life, but in some cases even improve outcomes, right? Whether we're collecting PROs or other things. So I just really, want to stress that this isn't just a field or a service that's nice to have. This is something that absolutely every place delivering cancer care should be incorporating.
I absolutely agree. And I think that's a great message to pass on to our viewers. So thank you. Well, thanks for spending time with me today. This was so fun. I always love talking about this. So
yeah, absolutely. Thanks for having me.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTableOnc. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, and LinkedIn. BackTable is produced and hosted by myself, Kate Baker.
Our production team is led by Kieran Gannon,
Aaron Bowles,
John Reyes,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again, and see you next time.